that be an asymmetrical gait if someone has a leg length discrepancy?
Well, it probably would be, depending on how much of a discrepancy there is, because there can be modifications or compensations that can be made when someone has a leg length discrepancy. If it's greater than 5 inches, or and even some books say 5 centimeters, 2 inches, 3 inches, you could still compensate for it, but after that you would have to put on some kind of a lift onto the shoe itself. But would it be asymmetrical? Yes, but there are compensatory techniques that somebody might do, like a lateral trunk lean or a toe-off gait, which is known as a vaulting gait, or a hip hiking, or there's a lot of different things that somebody could do when one leg is shorter, and that's a good question, Jade, because or one leg is longer, because that's something that we were definitely going to demonstrate on hopefully Monday.
Okay.
I'm going to ask you ladies and some of you gentlemen, maybe Devin, to bring in your high heel shoes so that you can walk with one shoe. And Devin, did you get that?
Loud and clear. I'll bring the 6-inch ready.
All right. So, because then we could see. I mean, sometimes, of course, a picture's worth 1,000 words. So,
right.
If we could see some, and you guys can feel yourself. So, ladies, on Monday, if you could bring in a high heel shoe. It doesn't have to be real high. Just some shoe that's higher than a sneaker than you normally wear. And for the gentlemen, what we'll do probably is we'll put on a posterior knee brace or an immobilizer or something like that to mimic like a CAFO, an orthosis that fixes your knee, so that we can make it look like or have the appearance of a longer leg. And then we'll see what compensations you make. Because everybody makes a little bit different compensation.
Right.
We also have the aging suits.
Yes, we can wear those on Monday also. So Monday we'll do just lap, right? Monday we'll do just lap.
Yeah.
We won't do any lecture.
So yeah, while the first lab is going on, the second lab will do modalities. Well, we'll talk about the hours too, because we'll have a longer period of time, and some of you may not want the review with modalities. Some of you may. So if you don't, you could just spend more time in the lab. So it depends on you. All right. I think not everybody's here yet. There's still somebody missing. Mr. D'Onofrio, I will make you co-host so that if somebody comes in, you can let them in. Because it shows up on your screen, right? Yes.
All right. I think we're missing 2. Oh, here's Chris. He's always late. All right. Maybe we won't be missing anybody right now. All right. Let me make you co-host. All right. Okay. All right, we will start. So we talked about gait, we talked about temporal, spatial parameters. Let's see, since I don't have any pictures up on my screen of what students are here, maybe I'll ask Jasmine. Jasmine, can you tell me the name in the gait cycle, what the gait cycle is referred to with Rancho Los Amigos terminology? Without looking it up, Jasmine. Jasmine? Jasmine, are you there? I see your name here, Jasmine. Andrew, can you tell me?
For Rancho Los Amigos, you said? Initial contact, loading response, mid stance, terminal stance, pre-swing, initial swing, mid-swing, and terminal swing.
Very good. And Joe, how about traditional terminology?
Can you call on someone else? I'll be prepared for the next question.
Ashka.
Yeah, I love you.
Yeah, so stance phase would be heel strike, foot flat, mid stance, heel off, toe off, and then swing phase would be acceleration, mid swing, and deceleration.
Good.
Oh, I knew that. Okay.
When does double limb support begin and end? Melissa,
You said double support?
double support,
That's the beginning and end of the stance phase.
beginning and end of the stance phase, right? So more specifically,
Heel strike, and then toe
well,
off.
yeah, some people say it's a phase between heel strike and foot flat, which is really load response. So load response maybe is the first time that you see that from heel initial contact to load response. The first period is double support, and then at the end of stance phase, the other period of all double support. So while I have you on, how much time do we spend in stance and how much time do we spend in swing?
60% stance and 40% in swing.
And how does that change when we run?
It gets. Ooh, that's a good question. Does it?
That's kind of common sense, right? Think about it. Would the stance phase decrease or increase?
It would decrease. It would increase. I'm just looking at your face right now.
No. I'm just asking. I'm just asking. When do we think that we would spend more time on the ground or less time on the
less
ground?
time.
Less time on the
Less time.
ground. Right, okay. So do we have any period of, do we have more periods of single leg support in running?
Yes.
Yeah, okay. Is there any time when we don't have one foot on the ground when walking?
No.
Is there any time when we have no feet on the ground in running?
Potentially, yes.
Okay, good. Let's see, who else is here?
Professor, I just have a quick question about one of the phases. So from the notes that you had sent us and the normal gait handout with the pictures on it, for toe off or pre-swing, it says that it's like knee and hip flexing, but then on the page with the pictures, it says for hip, it's neutral extension. So I just was confused, like which one it is. Is it flexion?
I think it's because it's talking about for pre-swing from terminal stance. It's as a phase from terminal stance to pre-swing. As we go from pre-swing, at pre-swing, the hip is sort of flexed. However, it's beginning to be flexed, I should say. So it's going from a neutral to slight flexion. That's
okay.
That's all.
Okay.
Okay. When are we tallest?
Mid-stance.
We're in mid stance.
Mid stance. And what are our movements, our pelvic movements? Do we have any rotation? Do we have any lateral displacement?
Yes, for lateral.
How much rotation do we have in the pelvis?
8 degrees.
8 degrees, 4 on each side. And how much of a lateral displacement?
Ooh.
The rest of them are pretty much the same. If you remember 5 centimeters or 2 inches, then you're good. You're good with the vertical displacement and with the displacement of the hips. So about 5 centimeters or 2 inches, right?
Okay.
Okay. When do we have the most knee flexion during the gait cycle? Normal gait cycle. Casey.
Would be during the initial swing.
Initial swing. And another word for initial swing is?
That would be acceleration.
Acceleration. And how many degrees?
Around 60.
60 degrees. Good. Good. Let's see. Who else do we have here? I'm trying to remember. Just now if you'll pick somebody so we could ask a question. You have the list of the people in front of you. Are you there?
Mm-hmm.
Hello? He left too? Jasmine,
Nobody's-
are you back again, Jasmine?
Yes, sorry, I was in the bathroom.
Oh, okay. What is pronation and supination of the foot during weight bearing?
During weight bearing, supination. So it's opposite during weight bearing. The supination, the tibia does external rotation, and then it's
What's happening to the calcaneus? And what's happening to the talus?
the calcaneus is.
Go ahead, you can find it. It's there somewhere, right? Andre?
For non-weight bearing, for supination is fatty. So we have adduction, inversion, and plantar flexion, and pronation is the opposite. So
during weight bearing, what is supination?
for weight bearing, you're saying?
Yes.
Oh, okay. So for weight bearing, the calcaneus, for supination, it would be inversion. The calcaneus, the tibia would be externally rotated.
Right, because of where the talus is going. So where's the talus going?
Oh, the talus would be abducted and dorsiflexion.
Right, right. Causing tibial internal rotation, external rotation. Good, good. All right, so I think you're doing okay so far. Let's see. I think there were some things we didn't talk about in this handout. So we talked about vertical displacement when it's highest, when it's lowest, highest at mid-stance. We looked at this little video. I think we skipped over this, but there's axillary crutches, or axillary crutches are also known as upright crutches, and forearm crutches are also known as loft strand or Canadian crutches, and some crutches have a platform attachment. We'll show you pictures of platform attachments, and the platform.
Come back.
Okay, he's on the phone. Now he came in. Platform attachments are when you can't weight bear through the longitudinal axis of the radius, the humerus, and the ulna. So you have a platform attachment, and a platform attachment would keep the shoulder in neutral, the elbow flexed to 90 degrees, okay? So we will practice with these platform attachments in school also. They're when people have multiple trauma, so maybe they're non-weight bearing on a lower extremity, plus they're non-weight bearing on their upper extremity, so you have to have a platform attachment. You could attach a platform attachment to crutches as well as a walker. Canes, there's different types of canes. There's straight canes, short base quad canes, large base quad canes. They're sometimes referred to as crab canes. All right, so we learn how to measure these also and how to use them. When we have canes, in which hand do we use a cane if a patient's right leg is affected?
Left side.
Left side.
Opposite.
Left side. And how do you measure a cane? Devin?
Oh, it's you're gonna have the patient stand next to the cane, and you're gonna measure it, like have them put their hand to their side, measure it right at the wrist crease, and then it should be like 10 to 20 degrees of elbow flexion, or is that for a walker?
No, it's a little bit more, but I don't think we've talked about that yet. And also, we're not going to have the cane exactly straight by someone. We have to have it 2 inches.
2 inches away from the foot, right?
4 to
and a 4 in front.
Right. But we'll talk about that. But yes, basically what I wanted, and you had answered the question, you're going to use the wrist crease or the greater stroke cancer in order to find a landmark for how to cut the cane. Suppose the cane is wood and you need to cut it. You would have to, because there's saws and all the physiotherapy, physical therapy, and occupational therapy, and you might have to cut the cane. Sometimes they have these, you can little toggle that you can bring the cane up and down, but if it's a wood cane, you need to cut it. So measure twice, cut once, right? So that you know exactly where you need to, because once you ruin that cane for the person, that person needs to get a new cane. Well, walkers, a Hemi walker is a one-sided walker, so a Hemi walker is larger than, it's not as stable as a walker, but it's much more stable than a cane. Okay, so Hemi walker, there's stair climbing walkers that have attachments that extend out from the hand grips. There's standard collapsible walkers, there's platform walkers, rolling walkers. Rolling walkers can have brakes, or they can be without brakes or with brakes, and you could also use a platform attachment on these. Parallel bars are what you put a person in when you have the maximal amount of stability is needed for that person. It's also for that early gait trainer. So if you bring your patient down to the department and the patient is multiple trauma and may have, what do you think they might be suffering from if they've been in bed for a while and you have them in a wheelchair, or it's the first time that they're getting up? What do you think might happen? Monica?
Muscle weakness or maybe contractures.
Okay, well, let's say they have, let me give you a little scenario on this patient. He's a right femoral fracture with a long leg cast, abrasions and bruises of the left upper extremity, ecchymosis of the left eye, and a contusion of the left elbow. So let's just say that's your patient.
Okay.
Been in bed for 3 days because they were suspecting he might have a concussion, and they just didn't want to make or they wanted to make sure there was no other head trauma. So they had special tests and everything, and they kept him in bed. And maybe they let him sit up a little bit. But for the most part, he was supine, or maybe with the head flexed flexed about 30 degrees while he was in bed. So what do you think when you're going to get him up? What do you think might happen? What can happen?
He definitely cannot use any crutches because of his elbow. He doesn't have the stability to use anything that might require like upper body strength.
Okay, but when I initially mentioned this patient, I said, I think it's best for us to get him up in the parallel board. Why do you think it might be better to bring him downstairs in the parallel board rather than getting him up at the side of the bed?
Instead of the side of the bed, because I feel like with parallel bars, you're able to have double support with two assistants, maybe from behind and in front of the patient instead.
Okay, well, I agree with you. There's much more stability with those parallel bars, yes. But what other things did we look at in January when we started looking at people on tilt tables and things like that? What other things did we say might happen to a patient when they were bedridden for a few days?
Too dizzy, they might have their blood pressure might swing up or down. He's not.
And we did mention something about blood pressure going down. And what is that? What was that term that we used?
Orthostatic hypotension?
Yeah. So we really would have to consider this person may suffer from orthostatic hypotension. Once you get him up on the side of the bed and you're by yourself, he falls. Now, if he's close to the bed and the bed is low enough, you may be able to get him back on the bed. But if the bed is high, or if he took a step away from the bed, he may fall and you would then have to support him. So if he's in the parallel bars, there's much greater stability when you bring somebody into the parallel bars to begin ambulation.
Yeah.
So these people you're going to see a lot of clinics will bring their people down into parallel bars to begin ambulation training. Okay. So next, the parallel bars are most stable. Next to the parallel bars is the walker. The walker offers maximum stability as well as mobility. It'll provide mobility much more than the parallel bars, because parallel bars, you're just restricted to the limits of the parallel bars. With a walker, you can walk anywhere you want. So, but it's difficult to transport if some of these walkers are not collapsible, especially if they're older. Nowadays, most are. But if they're not collapsible, it's difficult to transport unless you have an SUV or a larger vehicle. It's difficult to get around in crowds. You have a decreased speed of ambulation, and it's less stable than the parallel bars. So, and when you have a rolling walker, it's different than a traditional standard walker, because when you have a traditional standard walker, you cannot do a step through. You do a step two. With a rolling walker, you could actually step through. Okay, so it mimics more of a normal gait. Okay? The other thing we lose when we have a walker is we lose that reciprocal arm swing because we're moving the arms together. With axillary crutches, they're less stable than a walker, but much easier to store, much easier to get out, much easier to use. And you can mimic a more normal gait pattern. But an axillary crutch requires you to have very, very good standing balance, good upper extremity strength, as well as the trunk. So what are you using to push off? What muscles do you think you're using to push off? You have to have at least 25 degrees of elbow flexion, because it requires you to push off and to elevate your body weight and advance it from one step to another. So what muscles are you using to do that?
Your lats.
Your lats and?
Your triceps.
Triceps, yeah. So if you don't have good upper extremity strength, you're going to probably get a walker. So it really doesn't depend on somebody's age, but it depends on their strength, right? It matters nothing about how much they weigh, how tall they are, all that you don't even have to worry about. I mean, you have to measure them, of course, but that doesn't factor into whether or not they can use a crutch. What you need to know are, do they have the coordination, do they have the balance, and do they have the strength? So if I gave you a scenario when there was a 3-year-old or a 4-year-old, or even a 5-year-old, and Cindy could understand this, and most of you can also, because you've seen children and you've seen the way they run around and could you, if somebody had a long leg cast or a spica cast, a little child, and what's a spica cast? You remember? Think of the spica wrapping, where you wrap the pelvis first before you wrap the femur. A spica cast is when they have to put the femur into abduction when they cast the limb, and that the leg is non-weight bearing in abduction, and there's a bar. The person has a full cast on one leg and a half cast on the mid-thigh of the other leg, and there's a bar made of cast material that connects them. So the leg stays at abduction. So imagine this 5-year-old child with a spica cast trying to ambulate with crutches. Can they do it? No. Their balance is completely off, and the coordination on a 4 or 5-year-old or 3 or 4-year-old is not very good. So how do you would have to get this child a walker, and also think about how this child will go up and down the stairs. Could the child go up and down the stairs with an assistive device? What do you think? Devin, what do you think?
I think that it would be kind of difficult to get a kid up and down the stairs with like an assistive device.
Well, what would you do?
Like close supervision.
Close supervision. You think that kid's going to say, "Mom, I need to go upstairs"?
Oh no, probably not. I mean, this might be a little out of the ballpark, but maybe loft strand crutches might be a little easier to use than axillary crutches. I honestly have no idea. So.
A low-strand crutch is much less stable than an axillary. It requires a lot more strength and a lot more support. So how about going up and down on your butt?
Oh, duh.
That's what they have to do. And there are some adults that have to do this too. Okay? So you need good strength of the trunk, upper extremities. And what if a crutch were directly in the axilla? So there was a therapist that failed their practical. There was a student that failed their practical, and they were allowed to go out to clinics anyway. And they measured a crutch, and the crutch was directly into the axilla. And when the patient was standing, they were actually leaning on the crutch, and also the compression, because the crutch was too high, was compressing some vessels. What do you think will happen, and what vessels do you think are affected?
That person may develop wrist stroke, though. I don't know what vessels.
All right, Stephen, this is going back to last semester. Do you remember?
Compression of the radial nerve.
Okay, Brian, good. Compression of the radial nerve. And what's the compression, and where's the radial nerve coming from?
I'm trying to remember my
What divisions of the brachial plexus?
C7, right?
What divisions of the brachial plexus?
The lateral cord.
Oh, anybody?
All of them.
All of them? How many divisions do we have?
Well, Marmu.
Divisions, anterior and posterior divisions. What divisions?
Posterior.
Posterior division, all of them, right? So if you're going to be leaning on the crutch, or the crutch is improperly measured for the patient could have compression of the radial artery. Radial nerve. And if the compression is radial nerve, and it's more than a neuropraxia, and what is a neuropraxia? What's a neuropraxia?
It's like temporary compression of the neuron at the axon.
Temporary compression of the nerve. Transient, comes and goes. So what will they start to feel? Rod Neal.
Like a little bit like tingliness, but it should like go away quickly compared to other ones.
What are they gonna feel?
Like tingliness, I guess.
Tingling. Where?
Which one are we talking about? We're talking about radial nerve?
What?
Wait,
Where have you been?
I was just trying to catch up. Everybody was talking all at once.
Okay. We're talking about radial nerve.
Yeah, so it should be like around like the back of the forearm and the back of the hand.
Okay. And what muscles would be involved?
The wrist extensors and the finger sensors,
Anything else?
elbow sensors.
Okay. All right. And so what if this compression was long-standing? What hand deformity can be associated with it?
It's on by like wrist drop.
Yeah. Good.
Okay.
Good. All right. So we're bringing it back to everything that we learned last semester, right? Good. All right. So that all that could happen just because the axillary crutches are not adjusted properly or your instruction to the patient was not adequate. Because we always say to a patient, I want you to stand and not lean on the crutches. So if you're tired or you need to rest, maybe you need to lean against something or you need to sit down. But don't hang on the crutches because you have compression. And you can just say to them, because you can press some nerve that may cause tingling and numbness in your hand, and the patient may say to you, oh, so is that what's happening? Because I feel that on my sensation or I feel something is different in this hand. Okay? Also, with axillary crutches, maybe they're not the best thing to give with an elderly person that maybe is not coordinated or doesn't have the strength because they may feel insecure. So with those people, you may have to use a walker. Okay? Forearm crutches will eliminate this injury to the axillary vessels, radial nerve, radial artery. They're much more functional. They're easier to store. Who are these people that we said the other day that may be using these forearm crutches or these Austrian crutches or these Canadian crutches? Who are these people? Andrew? Mel?
Probably somebody younger.
Somebody younger, okay. Anybody?
More coordinated.
Somebody more coordinated. Any particular pathology, Mel?
Is it cerebral palsy?
Cerebral palsy, okay. You might be GP kids. Anybody else?
Someone with polio?
Someone with polio? Anybody else?
Muscular dystrophy involved.
Okay. How about paraplegics? Remember we said a paraplegic? Dave, do you remember that?
Yes.
Dave Nadler?
I do not.
You don't remember. Paraplegic. Remember we said they can have a swing to or a swing through?
Swing through, yeah.
Okay, we used to call it drag to and drag through, and don't use that terminology anymore. We say swing to and swing through. So what do you need to have in order to do that and swing your whole body that's paralyzed? Take a step. What do you need to have? What do these patients need to have when they're using these Austrian crutches? A tremendous amount of upper body strength. Okay? So do you think that somebody who is a cervical, a quadriplegic can use a forearm crutch?
No.
Probably not, right? Probably not. Okay, because they would need, as we said, a great deal of upper extremity and some trunk balance, some abdominals. And if they didn't have abdominals, it becomes harder. So we're talking about somebody who's a T6 patient, may be wearing a hip cuffo and a brace over the lower extremity and maybe try this. But what else did we say when we have any kind of pathology or any kind of compensatory movements that we have to understand that it comes with a great deal of energy expenditure also. So the less that you have to assist with, the greater the energy you need to expend. Okay? So cane. Cane is the least stable assisted device, and it's used to compensate generally for somebody who has a balance impairment or a little weakness or to improve stability, or if you have one painful lower extremity. So if somebody has a little knee osteoarthritis or hip osteoarthritis, you want to unweight that side. If you want to help unweight it, you could do that with a cane. Okay. So fitting crutches
Professor D'Onofrio last time talked a little bit about this, and we'll just go over this because, Casey.
I got it.
All right. Because when we fit crutches, you're going to stand the patient in the elbow bars. Proper fit is no greater than 2 fingers under the axilla. Okay? You're going to have the crutch. And the crutch is going to be approximately 4 to 6 inches in front, so anterior to the patient, and 2 to 4 inches out laterally. Okay? The hand grip is measured by the greatest trochanter, the wrist crease, or the styloid process of the ulna, and it's going to allow about 25 degrees of elbow flexion in order to be able to have that push off. An alternate way of doing this is you can multiply your height times 77% or subtract 16 inches of what the patient's height from the height of the patient. You could also measure, if you wanted to measure in supine, from the axilla, so you would place it in the axilla, and 6 to 8 inches lateral to the heel. Okay, so these are different ways that you could measure crutches if you needed to. If you needed to do it in other than somebody standing. Okay.
Would that be the same for a cane? Like 4 to 6 inches in front?
Yes.
Okay.
Yeah.
2 to 4 inches lateral?
Yes. Don't measure in high heels. Why?
So high heels are unstable?
Why else? You're going to get an accurate measurement, right?
Yeah,
Right? So you want to make sure that you measure in flat shoes. You want to make sure, and a lot of times when you measure a patient, when anybody sticks anything under your arm, such as a crutch, what's normal for a person to do? Elevate their shoulders, right? So you want to make sure that they're not holding their shoulders up when you measure, because once they let their shoulders down, you're going to get compression. Okay? So you're going to say relax your shoulders. You're going to place the crutch under somebody's axilla, and you're going to say relax your shoulders, so that they're in a normal stance, and then you can do the proper fitting. Okay? So again, patient supine, you use a tape measure. So you measure the distance from the armpit or the axilla to 6 to 8 inches lateral to the heel. This is what Professor D'Onofrio showed you the other day with his son. His patient was sitting. He had one arm flexed to 90 degrees, abducted and flexed to 90 degrees, and he measured from the olecranon process of that flexed arm to the tip of the middle finger of the extended arm. So the patient looked like this. I don't know if you can see me, but the patient looked like this. We'll go over that again. Or did Kevin share with you those videos? Did anybody look at any of those videos? Because all these videos are available for you to watch. Right? But we will do this because I think that if you do this, you'll remember it. Okay, we talked about that. Same thing with Austrian crutches. Same thing with cane and walker, 20, 25 degrees. With Austrian or Canadian or forearm, so those terms are used interchangeably, you also have to think about where the cuff is. So the upper edge of the cuff is 1 to 1.5 inches below the olecranon. Okay, so when we measure somebody with Austrian crutches, you have to take into account that they have this cuff that's attached to the crutch. All right. And we talked about what's the difference. Let's see, who didn't I call on? Brian Tobin? Hello, Brian?
Yes.
Okay. What's the difference between toe touch weight bearing and partial weight bearing?
Partial weight bearing could be unilateral, and toe touch could be bilateral, both not putting total weight on.
Does anybody agree, disagree?
Isn't it?
Isn't that toe touch just for balance?
Yeah.
What was that?
Toe touch is for balance.
Toe touch is when you're non-weight bearing. but it's just for balance. Okay? So, and that you have to clarify if a physician tells you they want the patient to put some weight on the leg. But toe touch is really not a weight-bearing status, so to speak. These are the weight-bearing statuses. Toe touch is somebody who is non-weight-bearing, who maybe you get them up and they have a balance problem, and you tell them they can rest their foot on the floor. They can't bear weight on it, but they could rest their foot on the floor to get their balance. Okay, and as they start to ambulate, they have to be non-weight-bearing. Partial weight-bearing, anybody? What does partial weight-bearing require?
Two assistant devices with partial weight bearing.
Very nice, Jade. Two assisted devices, right. Two assisted devices. And when you advance the crutches, which foot do you advance with the crutches? The affected foot or the unaffected foot? Jade?
The crutch should be on the unaffected side.
Well, we have two, right? You said you need two assisted devices. So if you have two crutches and you advance them forward, which limb do you advance with it? The affected or the unaffected?
The unaffected, yeah.
No.
No, wait.
Okay, and then that's okay because we haven't done this yet. But remember I said the other day, we consider the assisted device an assistant for our weakness. Right. So if we have a crutch and we have to advance some limb to take the weight off the limb, and we have two crutches, we're going to advance the affected foot with the crutch. Okay?
Okay.
I was just thinking about it in terms of like when I just picturing it in my head, like if you have two crutches and you put the affected side first, aren't you putting a lot of your weight on that affected side, bringing the unaffected foot forward?
No, because you're putting your weight through the hand grip of the crutches.
Okay.
And that's unweighting the limb.
Okay.
Okay?
Yeah, Oscar, the crutches and the affected leg go first.
Okay, so you're putting most of the weight on the crutch, not on the leg.
You're putting it on the hand grip of the crutch, yes.
Okay.
You're pushing, and then you're advancing your limb. Yeah, we'll do it. When you'll do it, you'll feel it.
Professor?
Yes.
Would it look a lot like pretty much how when we walk reciprocally? So you're bringing that right arm forward as you bring that left.
Well, then you're talking about 2 points. You're talking about 2 points. So don't mix them up. But again, Jade, it's difficult because we're only talking about it, so we haven't done it. So when we do it, I think it'll be easier for you guys. Or when you start watching these videos. And I would encourage watching the videos prior to Monday, so that you could, just try to understand it a little before we start doing it. But I think it's going to be easier, much easier when you do it. Okay? So we talked about this. Remember, 4-point gait, you need bilateral aids. It's left foot, right crutch, left foot, very slow. Right crutch, left foot, left crutch, right foot. Requires low energy expenditure. We discussed who is this person. So bilateral weakness or balance problems, or so both lower extremities involved. 2-point is that thing you just mentioned, Jade. It's that reciprocal.
Right.
So it's reciprocal crutch with right crutch, left foot, left crutch, right foot. Modified 2-point is one ambulation aid. So an example between a 3-point, which is non-weight bearing, or a 3-point modified, I should say. Let's go down here. 3-point modified is when you're partial weight bearing. 3-point is non-weight bearing. So let's say we have this 3-point modified gait. So we have two crutches. We advance them forward, and let's say our right leg. We'll always use our right leg. We advance them forward with our right leg, and then step through with our left leg. And we're getting pretty good. And we're also getting pretty strong. And maybe the physician says, you know what, to that patient, and to you, the therapist, I think they could start being, let's advance them to full weight bearing. All right? And they have these two crutches. And Do you think it's going to be easy for this person to get rid of both crutches and to start full weight bearing gait? Probably not, because there's going to be a great deal of weakness. There's going to be anxiety, fear, right? Maybe a little balance, proprioception, a lot of stuff, because maybe they've been partial weight bearing for 4 weeks, 5 weeks. You can't just take the crutches away and say, okay, now walk. So then I might say, all right, in order to get you used to starting to walk on both feet together and putting a lot more weight on that extremity that you've only been putting part weight on, what can you do with those crutches? What do you think you could do to make this person start to use the limb, not 100%, but a little bit more, getting them prepared for full weight bearing? Anybody? Anybody have an idea?
Weight shifting?
Weight shifting. But we're talking about ambulation. Let's not talk about exercise at this point, just ambulation. So how are we going to change these assistive devices? Are we going to change these assistive devices?
Can you bring them down to one crutch?
Sure. And that would be it, right? Requires one ambulation device or used with a patient with one functional upper extremity. Okay?
So wouldn't that just be 3-point, not, I mean, as opposed to modified 2 or 4?
No, 3-point is always non-weight bearing. The weight gait is never full weight bearing. Okay.
Modified 3 is.
Right.
Okay.
But now we take one crutch away. And remember, I said that person has a right leg affected. Which crutch do we take away, the right or the left?
The right.
The right.
Yeah.
Right. Because what do we say? When we have a cane or we have an assistive device and we have one leg that's weak, we place it in the opposite extremity. Increase the base of support, increase the stability, okay, bring the center of gravity over the base of support, take the weight off the affected limb, all that stuff. Okay, good. All right, so we said paraplegics, we said stairs, up with the good, down with the, or up with the affected, up with the strong, down with the weak, paraplegics. Okay, all right. Now, pathologies. We talked a little about pathologies the other day. We did a little bit of some videos, but we'll do some more today. Quadricep weakness. When are you going to see this? During what phase of gait do you think you're going to see these problems? For those of you who looked at your gait sheet, normal gait, when do you think you're going to see most of these problems?
Loading response?
Just load response, right? So from heel strike to load response, right? You think? Yeah?
Yeah, that's
I agree with you. Any other time?
Oh, swing pose too.
Yeah, maybe
Swing.
with initial swing.
Yeah, absolutely. During swing, you're going to see problems during swing phase. Okay. So if you have dorsiflexion weakness, go ahead, Ashka.
Just to clarify, during swing phase, your foot is mostly in dorsiflexion because you want to clear the floor, and you don't want, if it's in plantar flexion, you may have like a toe foot drag or a toe drag on the floor.
And you'll have a steppage gait, right?
Steppage gait, right?
Yeah.
Okay.
Absolutely. So dorsiflexion weakness, you could have an equinus gait. What's an equinus gait? We talked about that last semester or something. Plantar flexion, right? The toe strike first because the dorsiflexors aren't strong enough to hold the foot. So the foot can slap on the floor. So foot slap. These are the pathologies out of your book. And there's other pathologies that the whole gait evaluation form that I gave you, which is probably too much that you want to think about right now. But you could have a foot slap, weakness of the dorsiflexors, because what do the dorsiflexors need to do? How do they need to contract to control the foot from slapping to the floor? How do they need to do that?
Eccentrically.
Eccentrically. Andre, you look different than I do. I'll accept that. Okay. Drop foot results in a high steppage gait or a steppage gait during swing phase. Tricep story weakness. So what's the tricep story involve?
The
Gastrocsoleus, right? Which one of those is a two joint muscle? Gastrocnemius, right. So gastrocsoleus weakness with plantar flexor and inversion, right? No heel rise at push off. So that no heel rise at push off can result in a decreased step length on the other foot, right? What else can result in a decreased step length of the other foot? Anything else? Any other pathology? We did discuss this last year too. How about a sprained ankle? If you had a sprained ankle on the right and you had to step on the left foot, and that would be known as an antalgic gait. Antalgic gait is painful, which was probably on these slides somewhere too. But if we had a painful leg, or we wanted to get off that limb, we don't want to spend a lot of time doing stand space unilaterally, right? We don't want a lot of single leg stands. So we're going to take a short step length on the upside. So that's another reason why we could have a short step length.
I just have a question real quick. You said that to prevent drop foot, the dorsiflexors are contracting eccentrically?
Yes. To prevent foot flap. Foot flap. Drop foot, you can't do anything about. If you have foot drop foot, that your nerves aren't working and you result in drop foot. But foot flap is that control. When you strike that heel to the ground during heel strike,
okay.
the vertical line of gravity posterior to that ankle, it's going to cause that foot to slap on the ground. So what's going to control that so that you have a nice landing, so to speak, of that?
Right. So that's the same idea with like the quads preventing knee flexion as well.
Yeah.
Okay.
The same thing. The quads essentially control that. And the quads are really important too. I'm just getting off on a little tangent here. But for shock absorption, with those muscles, prevent shock absorption to the knee, protect them. Okay. Weak dorsiflexors, compensation consequences, landing with flat foot instead of heel. So in Aquinas case, foot flap, drop foot, steppage gait, all compensations and consequences. This is what's happening. Secondary effects. You have the weakness. Weak gastroc, no heel rise, results in a short step length on the unaffected side. Noticeable on level ground, but most pronounced on walking up an incline, right? Walking up an incline, you don't have toe off. Okay. Oops, sorry. Where are we? Sorry, hit that. Okay. Quadricep weakness, compensatory techniques if we have weak quads. A lot of different things. But one of the things we see a lot is Janu Rekavatam. So a person can lean forward. That leaning forward will distribute that center of gravity, will change the center of gravity, will shift it anteriorly. As it shifts it anteriorly, it causes, that line is anterior to the body, which causes the knee to hyperextend. The other thing that happens with Janu Rekavatam is that you could have reversal of action of the hip extensors as well as the plantar flexors, specifically that's the triceps. The soleus, because the soleus is a soleus and gastroc. Instead of the origin being pulled to the insertion and plantar flexion, the insertion will be pulled to the origin, and that will cause hyperextension. The other thing that you may see is hamstring weakness may cause Janu Rekavatam. With hamstrings and the glutes are responsible, especially during that terminal swing, to slow that limb down, right? And especially at initial contact, instead of having that leg swing out so far forward, it slows it down. So if it's not slowing it down, several things can happen. The leg swings out further, but because when we go into initial contact, you may see hyperextension. And the other thing is if you have quadricep weakness or hamstring weakness unilaterally, the opposite muscle is going to do more than the muscle that's weak. So if I have a strong quadricep and a weak hamstring, I'm going to go into Rekavatam, hyperextension. So normally during this explains it, normally during early stance phase, as you weight shift onto the stance leg, the line of force falls behind the knee, and that's just what I said. So if we're changing the vertical line of force and we're bringing it anterior to the leg, it's going to cause, because if it's behind the leg, it's going to cause the knee to bend. So if it's causing the knee to bend, then we need the eccentric contractions of the quads to prevent it from buckling. So if the patient will lean forward, it changes the center of gravity and it shifts this vertical line anterior to the knee, which pushes the quad back into extension. So that's what's happening.
Yes, sir.
Yep.
So when we say the line of force, are we talking about the ground force reaction
Yes.
that's
So
being created from it?
Here you see it. So this is normal. It's behind the knee joint. Now we're leaning forward, the ground reaction force anterior to the knee, pushing it in posterior direction. Okay, if it's behind, it's going to cause knee flexion. Remember why we said external forces require internal forces, or external moments require internal moments? That's what's happening. Okay, so as I lean forward, I can change that line. It goes anterior to the knee joint, pushing the knee back into hyperextension. Okay, so it doesn't require me to use these weak muscles. And you saw this a lot in the polio days. You know, people with polio, you still see it now, an anterior trunk bending. And if we continually anterior trunk bend, what are we going to wind up with here?
Anterior pelvic tilt.
You think anterior pelvic tilt?
It's posterior.
No, you could have an anterior pelvic tilt, but you're certainly going to wind up with tight hip flexors, right? So if you wind up with tight hip flexors, what's going to be inhibited? Everything that's back here. So you're going to feel a lot of weakness here. That's a little bit more advanced, but I just wanted to let you know that. Let's just try to get through this, because I think this is going to be enough. And we could talk, because as Professor D'Onofrio can tell you, when we start going into these deviations, you can see a lot of different things, and there could be a lot of different reasons, and you have to look. And that's when you really do your investigative stuff, and you look at these people in slow-mo to see what is going on, and then you have to do all your manual muscle testing to isolate specifically what's going on. That's why it's really important to know these muscles, okay? Because an inhibition of one side is going to cause, or a flexion of one side in tightness is going to cause an inhibition of the posterior muscles. Okay? Right, Casey? You with me? Casey? Casey?
He was having computer problems.
Oh, okay.
Yeah, sorry about that.
Okay. You agree, Casey?
Yeah.
Okay. All right. Hamstring weakness. During the deceleration, which we said, without the hamstring to slow down the swinging forward, the knee flaps into the new rectum into extension, and it'll flap into hyperextension. So that's when you might see Recker bottom. Okay. So you can see quadricep paralysis, plantar flexion contracture, right? Plantar flexion contracture, because now the tibia can't go forward, and you're going to have Recker bottom, hamstring weakness, hyperextension of the knee during stance phase. That's genu Recker bottom. Weak hip abductors. Two things can happen. Well, more than this can happen, but for now, the contralateral side of the pelvis drops. We know that. What is this known as?
Trendelenburg.
There you go. What does this refer to? Trendelenburg. So what happens? Contralateral side of the pelvis drops. The gluteus medius on the right is weak. The left drops. The trunk leans over the right during stance phase. Yes? And that's Trendelenburg gait. You agree? Yes, you should agree. Okay. Hip extensors, backward lean of the trunk during early stance phase, shifts the line of gravity posterior to the hip, and it reduces the demands of the hip extensor muscle. So we could use what did we do when we talked about last semester? We said we had a Trendelenburg, gluteus medius lurch, and we also said we have a gluteus maximus lurch, right? Remember last semester? This would be known as a gluteus maximus lurch. So we're using the trunk to extend the limb rather than the extensors. Okay. Hip flexion contracture is a salutation greeting the person. It looks like they're always forward because they're in hip flexion. Professor D'Onofrio, do you still have that? I think you do to some extent, yes? You had
Contracture?
no, not contracture, tightness. You had
Oh, yeah.
you had bilateral hip replacements, and he was, in order to keep the weight off the hip, he would bend forward and change his center of gravity. And plus, the muscles get tight over time.
In Dellenberg, who knows?
A
Let
fused
that figure it out Monday.
okay. A fused hip is known as a bell flapper gait. Okay. So, in order to best explain this, we have to say that if something's not working in one joint, another joint is going to compensate for it, right? That's normally what happens. So we have to compensate when we talk about compensatory techniques with muscles. We could also talk about joints. So if one joint there's something wrong at one joint, you may see something affected somewhere else. That's not uncommon. You see it all the time. Somebody has a foot problem and maybe it alters, or somebody has a hip problem and it alters how they walk, or where they put their foot. So if I have a decreased hip flexion or decreased hip extension, or problems with either one, or a pathology that, like a dystrophy or something like that, in order to get my hip to flex forward, if I'm not flexing my hip itself, then I can flex my pelvis. So how do I flex my pelvis? I posteriorly tilt it by decreasing the lumbar lordosis. Are you going to show it? Okay, he's going to show it. So I'm going to posterior tilt to decrease my lumbar lordosis. That will allow the hip to move forward. Okay, so that'll increase decrease the lordosis to allow the hip forward. If I want to move into extension now, I'll have to increase my lordosis, which allows that leg to swing posteriorly. Okay, so what's happening through the pelvis? I'm having excessive movement, and that's generally what you have through some a cerebral palsy. Did you guys talk about spastic diplegia yet? When you talk about CP, did you talk about spastic diplegia?
Yeah, we did.
Okay, so you did. So this should be a little review then. With spastic diplegia, these people, in order to walk, it's really, really. We used to have a gentleman he was in his 20s, in the cafeteria. I used to see him every morning. That had spastic diplegia gait. It was really something to watch. I mean, talk about energy expending. You have to decrease the lumbar lordosis, flex the lumbar spine in order to advance the limb forward, and then go into hyperextension of the trunk in order to have it decelerate or bring the limb backwards. Okay, so that's known as a bell flapper gait. All right, hip or knee flexion contracture during stand space. This is a crouch gait, that's spastic diplegia. And, I'm sorry, you know what? I talked about bell clapper, which this gentleman did. I was thinking about him. He had that and he had this. With bell clapper gait, you'll see the flexion, you'll see the compensatory movement, and the crouch gait is associated with spastic diplegia. So take that back, all right? I'm sorry, I'm just thinking about what this gentleman had. But a crouch gait is associated with which results in an anterior pelvic tilt, excessive hip flexion, adduction, internal rotation, flexion of the knees, plantar flexion of the ankles. We'll show you a picture of this. You don't have to really remember this at this point. Knee flexion contracture. If somebody's got a knee flexion contracture, they can have excessive dorsiflexion during mid-stance and an early heel rise at push-off, right? Excessive dorsiflexion during mid-stance because they have a knee flexion contraction. A knee fusion, lower leg is fixed. If this leg is unable to shorten during the swing phase of gait,
How can this patient compensate? This patient can compensate. Devin, you've said it a million times because I've heard you say they're hip hiking or they're circumducting or they're abducting. If the longer leg can't clear the floor, the person can hike their hip on that side. They can spin their leg around or circumduct it, where they can abduct or could even laterally flex to the opposite side. What else can they do? Compensate by vaulting. What does vaulting mean? Does anybody know?
Like the opposite leg?
On the opposite leg.
Right, so they come up on their toes on the opposite leg. So it looks like plantar flexion, that's what it looks like, on the opposite leg, because they're trying to make that leg longer so they can have this leg clear the floor. Okay? And you guys understood this, right? Because I'm just looking at this. It's excessive dorsiflexion during midstand. Dorsiflexion meaning, why does it say dorsiflexion if it's a knee flexion contracture? Why does it say dorsiflexion? If you have a knee flexion contraction,
your tibia would be forward.
Correct. So the tibia, instead of being at a 90-degree angle, would be forward on the foot, and forward movement on the foot is dorsiflexion. If the tibia is not at a 90-degree angle and it's behind the ankle, that's plantar flexion. If it's in front of the ankle, that's dorsiflexion. So the heel, the foot would already be in dorsiflexion, which would constitute an early heel rise. Which you're not, because that leg is already forward. Okay? Hip hiking. An impairment that limits the ability of the lower extremity to shorten and to functionally shorten. We said hip hiking can occur from weak hip flexors. So you're not flexing. So if you don't flex, you need to do something else, so you could do it for your pelvis. Condylateral pelvis will elevate during the swing phase to provide extra clearance for the advancing leg. Okay? Hip hiking. Circumduction, again, you'll see the swing leg advance in a semicircular arc, which creates extra clearance for the advancing leg. So what muscles need to accomplish this? Hip circumduction. What muscles? Is circumduction 2 degrees of movement or 3 degrees of movement?
3.
You could use
3.
2. Think of thumb abduction. Thumb circumduction is 2 degrees of movement. It's flexion, extension, abduction. Same thing with hip. Okay? Flexion, extension, abduction. So what muscles flex, extend, abduct? Anybody?
Glute med and iliopsoas.
Okay, Chris. Glute med.
For abduction, and then iliopsoas for hip flexion.
Okay. Anything else?
TFL.
TFL, right.
TFL, anything else?
Rectus femoris.
Anything else? How about glute max?
Glute max, yes.
Okay. Yeah, good. Okay. And vaulting, we said, on the opposite extremity, you'll come up on your toes. Your inability to flex or extend flex the hip or the knee, you'll rise up on the toes of the stance foot. So you're in swing on the right, the stance foot on the left. You'll plantar flex so that you can advance the limb and you can clear the floor. You'll make that leg look longer. All right. Plantar flexion contracture will give you hyperextension. We talked about that before. And early heel rise during push-off. Plantar flexion contracture. Ankle fusion. Triple arthrodesis. So triple arthrodesis. What's the difference between an arthrodesis and an ankylosis?
One is surgical fusion. The other isn't.
Which one is which? No?
Arthrodesis is surgical.
Okay. And ankylosis?
Is like calcification?
Yeah. No, it's it's a self-fusion. Right? And what's the difference between, if the triple arthrodesis involves a subtalar and transverse tarsal joint, then what motions are going to be affected? Subtalar joint. What's happening at the subtalar joint, Casey?
Inversion, eversion?
And what's happening at the transverse tarsal or mid-tarsal joint?
Is that abduction? No. Tell us some more.
Andrew?
Pronation and supination.
Okay, so there's a lot of things affected at that point, right? So it's going to be difficult to walk on uneven ground. How do we hit the ground? What position is the foot in when we heel strike?
Supination.
Supination, right? To absorb the shock of the ground, followed by, and that's a rigid foot, right? Followed by what?
Pronation at toe off.
In order to accommodate to these surfaces, to the surface of the foot. Good. All right. If we have cerebellar involvement, and you guys will talk about this next year, but you have something known as an ataxic, unsteady, ataxic gait. This person lacks coordination, so cerebellum is part of the brain. You remember that. And there's a lot of tracks that go through here, and coordination is a big thing that happens associated with cerebellar problems. Poor balance, so balance, wide base of support, uneven movements, and a lack of coordination. So we'll show some pictures of we'll show some videos, but ataxic would be an unsteady gait. The patient's lack coordination, balance tends to be poor. Patient walks without what kind of base of support? Narrow base of support. Patient usually has difficulty walking in a straight line, and all movements appear exaggerated. I had a patient severe cerebellar degeneration secondary to alcoholism, severe, and his gait was so ataxic he could not walk a straight line. He could not even stand without. So, what do you think we need to do with this patient? Provide mobility or stability?
Stability.
Stability. I actually put a gait belt on this patient and put 5-pound weights on each side of the gait belt, just hung them over. Plus I put weights on his ankles, and I did some stabilization with him when I walked. It was able to control him. He was able to walk in a straight line, but how functional is that? He can't go out into society and walk like that. But his cerebellum was so affected. He had such brain damage that he was not a community ambulator at all. He had to be in a wheelchair.
I personally had a patient that wore, I think it was either 15 or 20-pound weight vest just to be able to function.
Mm-hmm.
Yeah.
He had brain damage of some sort?
Yeah, it was ataxia.
Mm-hmm. Okay. Parkinson gait. Again, you'll talk about this next year. It's categorized by tremors and pill rolling as opposed to an intention tremor. It's resting tremor. Then they say pill rolling because they stand here and it's almost like rolling a pill. Pill rolling tremors are not an attention tremor. An attention tremor is more associated with cerebellar problem. Lower extremities in the trunk tend to be flexed, so the patient seems like that when they're ambulating, like they're catching, their trunk is moving forward and they're catching up with their legs are trying to catch up with their trunk. So the elbows are partially flexed, very little arm swing, very little reciprocal swing. Stride length is diminished. They shuffle their feet, and they have what's known as a festinating gait. And again, I said, because of the trunk being flexed forward, they seem to have this forward lean, and they're catching up with themselves as they start to go. It's difficult to get started, and it's difficult to stop. So the gait tends to start slowly, then it starts to increase with speed, and it's difficult to stop. And they have shuffling gait and cogwheel type movements. Okay. Scissor gait, we said the other day, is associated with adductor spasticity seen during the swing phase, narrow base of support. Trunk may lean over that stance leg as the swing leg attempts to swing past it. Okay, so they may compensate by a lateral flexion of the stance leg when the other leg is in the swing phase. Pain. You have a shortened stance phase. Antalgic gait. Remember I said somebody who has an ankle. Typically you think about an ankle sprain. And leg discrepancy, lower leg discrepancy. Antalgic gait. When any lower extremity joint is painful, the tendency is to shorten the stance phase. So you see a shortened, often abducted stance phase on the involved side, results in a rapid and shortened step length of the uninvolved side. So just remember if you have that ankle sprain, and why do we have a shortened stance phase on the opposite side, the uninvolved side? A shortened length
on the opposite side is shortened step length because the affected side doesn't want to spend a lot of time in stance. Unilateral weight bearing. That's why you have a short step length on the opposite side. Leg length discrepancy compensations can include dropping the pelvis on the short side, leaning over the short limb. If the leg length discrepancy is great, you'll see an equinus, so you'll see toe. The toe will touch the floor when you go into initial contact. And you could also see flexion of the longer leg in order to compensate for the short leg. All right, normal gait, I think we looked at. Let's just...
Professor?
Yes.
Yesterday, there was a patient with a leg length discrepancy in the longer leg.
Sorry. Go ahead.
The longer leg was actually appearing shorter. It was 3 centimeters longer, and maybe they were hiking it up because it was so much longer over time. They kept hiking it up almost to like balance themselves out or something. But it was interesting how the longer leg appeared shorter.
Yeah, because they did some kind of compensation. Yeah, absolutely. Professor Zanopia, would you be able to click on these and show them? Are you still there?
Yeah, I'll be.
Would you be able to?
I don't know if, let's see. But I can probably get that though.
Oh, all right. So let's see, Parkinson's, cerebellar, myopathic, Gower's sign. Oh, Gower's sign is really cool too. Gower's sign is seen with CP kids because they have proximal weakness. So they use their hands to stabilize their hips and their quads when they stand.
I'll show you that.
All right.
So let me.
Professor?
Yeah.
Going back on the antalgic gait, you said that the opposite leg, the unaffected side, would have a shorter leg length. Step length.
Yes.
Would the right one, when they step back down, would it be shorter as well? The affected side?
No. You see the step length difference on the opposite leg. Because during swing, because they'll take a normal swing. Those patients that have, that's not Gower's sign. That's not the one I want. I want a real patient. There you go. Okay. But do we have the one from him getting off the floor? See, the Gower sign that I had, he's getting off the floor. But this is okay. He's pushing up. All right. I'm sorry, Cindy. So just click on mine. Why don't you just cut and paste mine and put them in? Cindy, if somebody, that patient that you're talking about, they would take a normal step because in order to go from stance to your next, in order to do that step length, you would need a swing phase within that, right? So if somebody doesn't want to put weight on their leg, they don't mind when it's in swing phase. So when it's in swing phase, that swing step is going to be normal. So their step length on the opposite side is going to be affected, while the other leg, so if I'm stepping on, my step length is decreased on my left, my right leg is going to advance, right? Because one leg is in stance, the other one's in swing. As my right leg advances, it's not going to change its step length because it's in a non-weight bearing phase.
Okay.
Okay?
Thank you.
Yeah, have you sent me your the lecture? I can cut it from there.
All right, hold on. Let me see. Wait a minute. Where are we? You know, it's 10 of anyway. You want to take 10-minute break and then we'll go over some videos and stuff? Should we take 10 minutes? Guys?
That sounds good.
All right, let's take 10 minutes. We'll come back. Okay.
Let's make it bigger. I can also control the speed if we want to.
Do you want me to replay it, Dr. Sess?
Well, I want some comments from the peanut gallery here.
Yeah, right side seems a little kooky.
All right, I'll replay it. I'll put it a little bit slower for you guys.
So who is this masked man?
That's me.
Yeah, you guys don't recognize him?
That's Batman.
What do you see? You see anything?
It looks like I'm limping on the right side for some reason.
Yeah.
To the right side.
Yeah, I noticed that too.
I have no idea why that is.
Andrew, did you send me a front view too? I didn't see the other one. I just checked to see this one worked.
Yeah, I did send you a front. Like I walked towards the camera in a way, so it's like a front and back.
You also, what are you seeing as far as hands? What are you seeing as far as any kind of a swing? What are you seeing as far as any muscles that are popping out to you anywhere? What do you see?
Reciprocal arm swinging.
Do you see true reciprocal arm swing there?
Not a true, but it's just like the contralateral side. Or sorry, ipsilateral side.
Can we see this from
front view?
I see other things, but can we see a different side?
Yeah, let me do front view. Give me a second. So, let's pull this up. Back.
So we could break those videos down into specific joints for everybody, and instead of being overwhelmed trying to look at everything. Because I saw some additional things as well.
Could be just me, but it looks like his right hip hikes a little higher than his left.
You guys if you had your shirt off.
Wow.
I don't want to be that guy who takes his shirt off at the gym.
No, you now have permission to be that guy, Andrew. So be that guy.
I'll never be that guy.
It's science.
You got
I could be that guy.
You got it wanted. What do you see? Anybody see anything?
There's something going on at the hips.
Hip drops a little bit on the left.
Maybe.
A little.
It's like his right hip is tight or something.
There, his hip drops a bit on the left there.
So that's not his pants?
So that weird way his right leg comes out.
You got something going? Well, Andrew knows that you yourself said it looks like you're limping a little on the right. Do you have something going on with your right leg?
No. Which is why I'm like confused. I don't really see it here. I saw it more from like the side view.
Mm-hmm.
That's the thing. It's not like, nothing that I'm aware of anyway. Which is why it's weird to me.
And did you watch it slow motion?
The lateral view?
Any view?
Yeah, I watched the lateral one and I was trying to kind of figure out what it was, and I couldn't really put my finger on it. Because like I said, I don't see it that much in this video as much as the other one.
Take them all the way back to where we see them from a posterior view.
Okay.
Can we blow this up at all?
This is the, well, actually, no, I think this is it.
Okay, and can we focus, can you slow it down and just focus on the, everybody focus on the calf? Bilateral. And somebody said they think something's going on with the hip on the left. Is that what you said, Chris?
No, I mean, the way his right leg is from the anterior view, it looks funny to me. I didn't think it was the left, but I'm not sure, you know.
Oh, it's fine. And you see a lot of medial gastroc activity on the left. You could even see it. You could even see it from a sagittal view when he was on the treadmill, compared to the right. You see that?
Andrew, can you stand in front of the camera, sort of like a posture assessment, so we can see from the side?
Yeah, let me try to set this up.
Oh, that means we have to see you. Did you comb your hair this morning?
I didn't. I'm glad I put a shirt on though.
Oh, take it off.
I mean, I think she's being serious to look at posture.
Well, if you don't mind,
To look at posture,
yeah,
that is actually a serious thing.
Is that good right there?
Should be good. Let's spotlight the video.
Spotlight, yeah. That's your bicep right there.
Can we make it bigger? We can make it bigger, can't we?
It's kind of it's based on the size of his webcam. So
Yeah, I see a lot of when he was walking too. I mean, his head's to one side, his trunk's to the other side. Can you guys see that?
Like his right side is laterally flexed.
Yeah.
yeah. Actually, yeah. Stay where you are right now.
Yeah.
Andrew.
Now this would be a great time to use the swordfish, whatever it is.
So is that the erector spinae pulling up on that right hip, maybe? Maybe the QL?
Could be either one. And you see, he's really laterally flexing. Yes. His head is laterally flexed to the right. His trunk is laterally flexed to the left. You see that, right?
Yeah.
If we had a plumb line we could drop on him, it would be very clear.
Yes. Yes.
Flexing to the left?
Look at that, yeah.
Yes.
Yeah. So hold on a second, Andrew. I just took a screenshot for blackmail purposes, and so all right, let's try this. Let's just look at this, and so you gotta see the picture. And so if we drew like now this is gonna be based on my ability to draw a vertical line.
Andrew, can you see this? You could.
Yeah. Perfect.
You see what we're looking at? The lateral flexion to the right of the head, the lateral flexion of the trunk.
To his left, it looks like he shifted a little bit more on his.
Yeah.
Shifting to my left, right?
Yeah.
Yes. So the trunk is flexed one way, the head is flexed the other. One shoulder is lower than the other, you see, of course.
Right. It looks like your head is a little bit shifted to your right, and then your trunk is shifted a little bit to your left.
Any scoliosis?
Yeah.
But when you say lateral flexion, wouldn't it be his right side? Because that's the side that's.
Let's see him from no, he's definitely laterally flexed to the right with the trunk. Let's see you turn. Let's see you from a posterior view.
Oh, well, hold on. Then I gotta stop sharing screen again.
Okay. And just relax. Yeah, that's better. Can we see anything? Look at those dimples. And look at the inferior angles.
Oh wait, yeah, actually.
Look at the carrying angle.
So yeah, Dr. Stutz, what I can do is I took a snapshot again so I can share that in case.
Yeah, the carrying angle on the right is a little bit larger.
Right. So if you guys are looking, she's saying look at the carrying angle, like look at the inferior angles.
Yeah,
right?
as it says, right shoulders.
Look at the angles right here.
But the right lat is a lot more developed than
the actual dimples.
Mm-hmm. And it's hard to be. I mean, Andrew, thank you for doing this because it's not easy to be, to be looked at and to be pulled apart. So this is the kind of stuff I was seeing when he. Let's look at his. Can we get it down to your calf, to your legs, to your feet?
Now, Andrew, you have no pain, correct?
Good. No.
No.
There's no pain, but these are movement patterns that he's developed over the years that may be faulty. The fact that he has no pain is a good thing, but he has some decrease. Okay, look at the calf.
Yeah, the medial left calf is like more hypertrophy, right?
And you could definitely see that during gait, and I also saw early heel rise. But that's what I wanted you guys to see. What do you think about as far as even atrophy or hypertrophy or difference in, maybe not atrophy or hypertrophy, but maybe a difference in girth?
Yeah, on the left leg especially.
Let's look at the internal rotation of the shoulders too. I want to see what's happening with the foot. It's so hard to do from here.
Master, you said you saw early heel rise with which leg?
Left. That's what I saw. But, I want you guys to look at this. There's other things I saw, and Anita, you saw some things too, right?
It looked like he also rotates more on one side than the other when he was walking.
There's more rotation, absolutely, Kevin. But I wanted them to pick that up, and I'm sorry. I wanted them to pick that up, but that's what we were talking about, the rotation and the side bending. And Devin, you're on. In a neutral posture, rotation and side bending occur how? Devin, wake up. Where are you? You went to work? Where's Devin? Joe, you better be texting Devin. Tell him to get his butt back in front of the computer.
I'll text him now.
This is lab time.
He's so busted.
He is. See, it's a good thing I called on him, so you guys know, don't walk away from the computer.
Andrew, do you feel like one leg is stronger than the other? And if so, which leg?
Not really. I mean, I think if I squat sometimes, I think I tend to shift.
Oh, can we see your squat?
Yeah. Turn towards us and squat.
And where should the knee go? Does anybody know where the patella should go? Where should the patella go? As you squat. Turn toward the camera. Okay, pick up your pants. Can you roll them up a little bit at the bottom so we can see your knee?
That good?
Yeah, can you roll them up, cuff them?
Kind of like baggy.
Yeah,
Roll them up on the waist.
Yeah.
Yeah. Just roll them at the waist.
Roll them up, man.
Do your best, Steve Urkel.
Now you look like an old man. Okay. All right. Can we also see the foot? So let's bring the camera down a little bit so that we can see the foot and the knee when you squat. All right. Where's the patella supposed to go as you squat?
Is it supposed to track laterally?
What toe should you be following? Anybody know?
Isn't the second toe?
Second toe. Yeah. So let's watch him squat.
Squat. Yep, squat.
Okay, get your hands out of the way. Oh, man. See that left leg?
It like zigzags.
Yeah.
Oh,
And it goes out a little more too.
yeah. And what side do you say you feel stronger on?
I think I tend to shift my left.
Kevin, can you screenshot that when he's at the bottom?
Yeah, let me just get it set up. Yeah.
And then Anita, you can put it in your snap whatever.
So Andrew, can you go down and just hold the squat at the bottom for a second? Yeah. Okay, I got it. It's good. And then, oh man. Okay.
There's something going on there, right, guys? You agree?
Yeah.
Yes?
Yeah.
Yep.
Is that why we think that maybe he showed a little limping on the right? Maybe, huh? Maybe.
I don't know if this is the angle, but like his anterior tib on the left also looks like it's like popping out.
Right. Let's see you from a lateral view.
I think it rotates. Which way?
Externally, it looks like.
Yeah.
Absolutely. Let's see. Oh, what are we beginning in already right here?
We're already in external rotation, looks like.
And a little bit of hyperextension.
What else?
Oh, yeah.
Yeah.
At the bottom.
Yeah, record better.
Yeah, so that's
You're just all messed up, Andrew.
They know what I was signed up for.
Let's see what.
Squat again.
Yeah.
One more time.
Now, face the wall.
I didn't see much that way. I don't see that.
No. I'm looking at calcaneal.
Yeah.
What's going on with the calcaneal? And now let's look to see if we can maintain.
He looks a little more pronated on the left foot too.
I was just about to say that. I don't know if I was over analytical.
More calcaneal valgus.
Yeah, okay. Let's see what. Let's see the squat. See when to stop. Keep going. Squat. Just stick your butt out. No deep knee bend. Squat. Stop. Oh. Don't go over.
That left leg.
Yeah.
It really comes out. Yeah.
Come back up, Andrew.
All right.
So wait, you want him to cut off his depth?
Yeah.
Says?
Yeah.
So just kind of go like here.
Goes that left knee.
A little more. Yeah, probably right there. It's a little hard to see because of your shorts, but yeah. All right, you can come back up, Andrew. So I did take the screenshot from the front view, and I could just share that real quick again so you guys can see.
All right, Andrew, you can sit.
All right, so if we're looking at it,
well, keep your shirt off.
Yeah. Right, like you guys can kind of see here that the left leg is at a different angle compared to the right leg.
You see what's happening to the left hip? What's it doing? Is it flexing?
It's externally rotating.
Is it externally rotating? What else is it doing? Is it abducting?
It's abducting. Yeah, I see her. When the posterior view of the squat, I saw the right hip shift, kind of laterally as that left knee abducted, I think.
Right, so we're getting abduction of the hip.
More abduction.
Right? We're not getting flexion of the hip. So maybe he's got limited flexion.
Wait, can you put the picture back?
Yeah, I can put the picture back.
Go back to the posterior, the picture.
I don't have a picture of the posterior. I only have the picture of the anterior.
I mean, what I saw in the squat, whether the left extra rotation of the tibia, but it seemed like there was rotation of the pelvis, that like the left butt cheek was closer towards the screen.
What's that?
You know what I mean? Like there was like there was some rotation.
Oh, he does.
Hip as much, so you saw some rotation to compensate.
He's got rotation through the chunk too.
Yeah.
Absolutely. Yes. But he's got and with Andrew, when we start to do, we'll just be a perfect patient. Like before I was working with Andrew, when we started to do goniometry and manual muscle testing to test those muscles around the hip joint, and to look at what's going on in the ankle itself. There's a lot of stuff that's going on, and it could begin at the head, and the head going one way and the trunk is going another way. And we talked about, we didn't really talk so much about Fryette's laws, but I told Devin to look them up. Devin, are you back?
Yeah, I'm back. My bad.
Yeah.
I had to go to the bathroom so bad it was time.
Well, we just came back from a break. You must be drinking a lot. Okay.
Oh yeah.
Okay. So, as far as a neutral position, if Andrew were, I don't forget where we said he was rotated or side bend. If he was side bend to the left, then what could be happening?
You're talking about specifically Fryette's law?
Yeah. What could be happening?
So in either flexion or extension of the spine, it's going to choose like a type 2 coupled motion.
So what are we talking?
Which is going to be lateral flexion and rotation at the same time. So right lateral flexion and right rotation. So if he's side bending to the left, he's going to get left rotation as well.
In the neutral position?
Oh no. Hold on, I have these written down somewhere. Oh no, when the spine is neutral side bending to one side will be accompanied by rotation to the opposite side. So he's going to rotate to the right.
Correct. So what does that mean when we look at somebody as far as range of motion? If we ask somebody to turn to the right or turn to the left, that's rotation. If we see they have a limited right rotation, where are they going to have limited side bending?
On the left side?
Yeah.
Yeah.
And that's really important. That's really important. So we would really have to look at these things with Andrew when we have him back. And we could look at these things with a lot of people. And I mean, it's normal for Andrew. He doesn't have any pain. But over time, he may develop some, and I'm not saying he will, but he may develop some little click here or some little joint problem here, just secondary to what his normal mechanics are. And he may never, but, these are the things that we're looking at. All right, let's look at somebody else.
For clarification, I thought he was bending to the right, not the left. Laterally bending to his right.
All right, let's look at them again when we have next class.
Yeah.
Look at them because then we could, you could take the shirt out of the way and you get a better view of what's going on and you could see them from totally, from head to toe. And we could also use Anita's got this dark push thing and we could be a little bit more specific or a little bit more scientific. So, and you guys any of you tried it at all? Dark fish?
In the past, but not in this like recently.
Do you have it for free, Asta?
No, I was through school, so I used the program through the school I was in to do like a gait analysis. I might have my lab saved, so maybe if I could find it.
All right.
Yeah, like I said, I was gonna look into it, but I haven't actually had the time to play with that yet. So
Starfish.
Yeah.
It's $240 a year, so you can do it, Kev.
I mean,
and give me your account number.
Sure. All right. I mean, I'm pretty sure there was one that was like $5 a month. So I think on just your phone. So I don't know. That's why I was like looking into it because I don't feel like spending $300 on it. But
well, all right. It would be nice if we could get that through the grants, maybe.
Yeah.
We'll get through so that we can.
I don't know. I don't know if anyone has it or knows about it, but it's essentially the exact same thing. But I think I have it for free.
What? You have the same app, or you have a different app?
It's a different app. It's called Coach's Eye, but you can download it for free.
That's what I was thinking of using. They use that for baseball.
That's what I heard. That's what I was looking into too. So I was like, I don't actually know what the difference is. I was trying to figure out what the difference between the two is.
The difference is price.
Yeah. Okay. Right. Okay. Well, I mean, that's good enough. If it's free, like, I just didn't know if Coach's Eye you had to pay for it too. But I was.
There are in-app purchases, but you can do everything in the app without buying it, and I don't think there's a subscription because I've had it for like 6 years and I've never gotten charged with it.
Nice. Okay. All right. I'm gonna make note of Coach's Eye. Download that. All right. So we're gonna look at another video. All right. So let's share the screen. All right. Make this big.
And who's this?
This is a video I got from Marissa.
That's my boyfriend.
I would assume. Yeah.
Can we rotate that somehow?
Hey, how are you? Not too bad.
Oh, you mean rotate this part of the video? Yeah, I can't do that with YouTube. We'll just watch it from the front view.
I see a lot of eversion on the right foot.
Something going on the right, yeah.
Like, especially on this next step.
Ooh. Well, what else do you see on the left? You see something on the left.
Hyperextension under that.
There's something else. Look at when he goes into initial stance.
I don't see much of a heel strike.
Yeah, there's like a lack of
On the left.
Is that excessive adduction, adduction? Hip should adduct, but not that much. But you know what? I'm going to be quiet. Let you guys watch. You could see it anterior and posterior.
You said the hip?
One foot is straight, the other one's more out, like toes more out.
The thigh is adducting, right? Why? Look what's happening to the foot when it hits the floor. Do you see that? Gives the appearance of having greater pronation too. But it's happening from the hip.
Just to clarify, you're looking at that right hip, correct?
No, I'm looking at the left.
Left hip.
Mm-hmm.
So the left foot looks more pronated and the right one looks more everted.
And what else does the hip look like it's doing? Where are the toes going? Look at that.
You're talking about the left hip?
Yeah.
I don't see it.
Can you pause it when you see it?
Right.
I'll pause it wherever you guys tell me to pause it.
Right there. Back maybe a quarter of a second.
Okay, go back one.
Think he has much of a thick ankle? Normally it should be about 7, 8 degrees. If there's a range.
So if you're looking, this foot is perfectly straight. And what Dr. Stutz is mentioning is, are our toes supposed to be pointing perfectly straight? Like perfectly in line with how we're moving? Or are our toes supposed to be going out a little bit?
Yeah.
Should be going out a little bit, about 2 inches, is it? 2 to 4 inches?
2 to 4 inches?
No, 2 inches.
Go with degrees. You usually want to go with degrees on this one.
Thick angle normal is 12 to 18 degrees, correct, in adults?
Right. Does this look like 12 degrees of going to the side?
No, and he looks like he has an excessive thick angle on that right side.
Right.
Actually, it looks like he has a minus thick angle on the left, doesn't it?
Mm-hmm.
Would that be coming from the hip? Could be, right?
Yeah, could be excessive or some internal rotation.
And if we use internal rotation, and it looks like we also have an increase in adduction during stand space. I mean, you have normal adduction, but it looks like he's got an excessive. So what might that indicate?
Tight adductors, weak abductors.
Yeah, I'm sure. That could be absolutely. Could be tight adductors, weak abductors. Weak external rotators, yes? Any of those, we don't really know until we examine them, but I mean, that could be something that's going on. Do we see, we can't see any trunk, can we? Can we see a trunk?
I don't know if Marissa has one of the trunk.
No, that's all I said. I'm sorry.
That's all right. But so as you guys can see, if you this was just to get you guys to take videos. But if you can, try to get the whole person in the frame when you're making these videos, because there could be stuff going on at the trunk or the neck that we might want to look at. Right. So Dr. Stutz, that's basically it. Should I just go to another video?
Yeah.
Okay. All right. So,
And Anita and Linda, if you guys want to make everybody should make comments if you have anything you want them to specifically look at, or, feel free. Wow, this is a fast gait, isn't it?
you just wanted to get it over with, that's all.
This would be a good time to be able to measure that step length.
I'm gonna say, well, she's stepping forward with the right side.
Yeah, definitely. Could you attribute that to like tight hamstrings or?
Now, how do we know somebody's got tight hamstrings?
Well, we have a bunch of tests.
How?
90-90 test.
90-90 test. Okay. What else do we have to look at during the 90-90 test?
Yeah, if you just go back and forth on this angle.
Because it's tough to see, because she's got a jacket on and everything. It's tough to see what's going on with the hip trunk.
Well, it seems like coming from the front, we might be able to see something.
Can we go from...
Oh, you mean from...
It's from an anterior view. Like, even though it's, like from there forward.
That's interesting.
Mm-hmm.
She's sort of like internally rotating that right hip.
Looks like she's stepping out further with that left hip. Left leg. I don't know if it's because it's the.
Well, I mean, when the right side comes through, it looks like she's almost like
narrowing,
rotating the hip.
Look at the motion of her ankle on her right foot.
It's like if she were dragging her ankle like forward.
Yeah. What would cause that? What's going on there?
Like right here, especially.
Right there.
Oh, she's going this supination on.
Boom.
Pronation of the right foot.
See how much her right foot pronates as compared to her left?
Yeah.
If she didn't have shoes on, you could see it much better, but it's still evident.
Also, I don't know if this is just the angle at which the video is taken, but it looks like her right, when she steps with her right leg, she steps like it's more adducted, it's more in front of the other foot versus when she steps out with the left, it's like out more to the side.
You're talking about the hip. You're talking like she looks like she's out.
Yeah, the hip.
Instead of flexing it. I agree with you. What else do you think about that left knee?
Yeah.
That's what you saw, right? That's
the first thing I saw. Yeah, that's what it was.
Yeah. What do you say? What do you think?
The left knee?
Yeah. I thought the right knee looked like kind of
Yeah.
Oh.
Yeah, it looks like it's hyperextending when she puts her foot down.
Well, it might be. We don't know. But from this angle, what do you think?
Is there a valgus in that knee?
And it looks like when she extends, her patella like moves like back. I don't know how to explain it.
That's good. I mean, you're all doing good observation.
I noticed the valgus.
Yeah. Yeah. So, Joe, you saw that. Yeah. Very good. Again, we would have to look at the whole body and see what's going on. But those are good points. You guys picked up good points. You saw something in the ankle on the right. You saw something with the knee on the left. You saw something with the hip on the right. And, to confirm these things, do you have any problems? That was Jade, right?
Yeah.
Jade, do you have any issues?
I do hyperextend my knees.
Yeah, we saw that too. But do you have any pain? Do you have any pain anywhere?
Can you hear me?
No. We hear you now.
Okay. No, I don't have any pain.
Okay. All right. You guys like this?
Yeah.
Yeah. It's good.
Yeah,
Is anyone struggling to see this? If you're not understanding what we're looking at, make sure you let us know. Because we can't
it's
see
also really fresh.
Yeah.
So I think once you practice.
Yeah, I mean, you guys are not expected to see everything at once. You're gonna have to watch it again and again and again, and focus on every time you look. You should focus on just one joint when you're starting out. Just only look at the ankles, right? And then only look at the knees, and then only look. You gotta watch the video a bunch of times, over and over again, and then you'll start to pick out things, and they're gonna pop out to you. But right now, if you look at the whole body, that's probably not gonna help. Right? You gotta try and look at one joint at a time. Dr. Stutz, should I put in another one?
Yes.
Okay.
At times I feel like I'm looking for.
Linda, you with us?
I'm with you.
Okay. If you have anything else that you'd like to point out, I mean, I don't want to.
I was noticing some things, but nothing major with that. I was looking more at the ankles, the foot, the base of support, and the leg.
Yeah, absolutely. Well, after if you have anything that you want that you feel that they missed or we didn't talk about specifically, just I don't want to let anybody think that, we're dominating the.
No, thank you though.
All right, who's this, Joe?
Oh, Steven, do you have a question?
This is Dan.
Oh, Dan, okay. There's a lot
Rock in the Crocs.
up, right? It's like rocking and rolling there.
What like?
Like a bit of a Ellenberg, I feel. That's it.
Well, you gotta be careful because the shirt
is
the
a
shirt's not gonna tell you anything.
It's going to give you an illusion.
Yeah, that's why we usually say you should try to be either shirtless or something, because if you just look at the shirt, yeah, you'll think it's a Trendelenburg.
Yeah, sorry about that.
But also the flip-flops definitely could change somebody's gait.
Correct. So you have to make sure they're wearing appropriate shoes or they're barefoot in the clinic.
I'm not sure.
Puts those Crocs in 4x4 mode, man.
I'm not sure if, but I feel like he laterally flexing his trunk to the right. I'm not sure if it's a shirt illusion or not,
But even if, yeah, I mean, that's a good point. At least look at the angles, the carrying it.
Yeah.
Well, just from this view, I could see that his left scapula is higher than the right.
He used to have a lot of trunk rotation going on, right?
Yeah.
Shall we try another view? Because I think, Dan, you gave us a bunch of views, right?
Yeah, I gave you all 4 directions.
Okay. So let's try from front view. We'll start from like right here.
I got a model out here.
He looks like he's about to walk in and start some stuff.
Looks like a model.
Is it choppy for everybody, or is that just me?
Yeah, maybe it's just because it's so slow that it's coming off a little choppy.
I go faster? I'll go faster.
He's got a lot of his typical arm swing, which goes along with a lot of what's going on with the trunk, right?
Yeah, we call that swagger.
The arm swing and the trunk are working.
That's not necessarily a bad thing, though, right?
No.
I don't know who said it earlier, but I do see a little bit of that lateral flexion on the right.
You got your New York City parallel walk down perfectly, though.
Hey, dude. This guy crosses at green lights.
Can you slow it down?
Yeah.
You can clearly see my pointer there.
Dan, do you run?
Bill kyphosis?
No, I don't run.
Mm-hmm.
Got a large step length.
He's tall. Yeah.
Yeah.
So, and he walks fast.
Well put together.
Interesting. You see a little bit more rotation from this view than you do from, and I don't know if that's just the camera angle.
Is it more rotation right than left?
Yeah. Yeah, that's what I see too.
So when you say more rotation right than left, is it like the body's rotating to the right or to the left, or it's the right side rotating more?
More, so the left rotating more to the right than the right coming left. Whether that comes from the spine, whether it comes from the hips.
Yeah.
Go back and see.
Yeah, no, this is.
So what they mean is like you can kind of see more of like his chest from this side than you can on the other side.
Oh, we'll look at him in lab too. We'll look at everybody in lab. All right.
Yeah, I guess what you guys are gonna find out is you're all messed up and you all have different gait deviations. But don't take it personally.
I've never been more self-conscious in my life.
You guys, that's what makes gait so fun. No two people walk the same. Everyone's got their things about them.
Right, and you think you're completely fine, but like when you actually look at it, you may have some deviations that you never realized you had.
Mm-hmm. Yeah, like you really saw Dan's forward head there, right? Which a little kyphosis, little forward head, which you don't really notice. Sorry, Dan.
No, it's good stuff.
You picked it up. Okay, good. Steve, not Steve. Dave, do we have any of you?
I don't have anything from Dave. Dave, can you share it with me right now?
I actually forgot to record the videos, but I will record them because I know my leg
one
is super
job,
messed
Dave.
up.
One job.
I know. I have super flat feet. I have junior record bottom.
All right, you have to
Nice
give us.
see.
We expect at least a minute and 30 seconds of video from you.
Does that mean you're going to grade those history papers in a minute and 30 seconds, Kev?
Which history? Oh, you mean the ones from last semester? Yeah, it's on my to-do list, man.
They were looked at. They were looked at. And you guys all got adequately down on those papers, so. Do not complain about them, because we bumped you up a little bit in your final grade.
Should I just put someone else, Dr. Sess?
Yeah, let's put, Steve, do we have you? Steve?
Oh, you have one from my sister who's probably more messed up.
All right, let's see.
Did you email that to me, Steve? Because I know you texted them to me.
It's on the drive.
Oh, it's on the Google Drive? Okay. Let me upload it then.
And they're already in slow-mo.
Okay.
Oh, see, Dave? Now that's the kind of student you want to emulate.
You telling me I want to be just like Steve?
That's it.
No.
Wait, which drive is it on?
You're going to start watching movies in class.
I sweat less. Hey, bro, no.
You watch movies during class time? I'm going to come around now.
What a low blow.
Wait, Steve, which drive is it on?
Anybody else have one submitted? Kyle?
Yeah, I have one. I did. I submitted one to Drive. I emailed mine because I didn't know how to get it onto the.
Oh, you emailed? Wait, hold on a second. If you emailed it to me, I didn't get an email. Wait, okay, let me actually. No, I didn't get an email from you either, Joe.
No?
No.
I didn't email mine, but mine's on the Drive, I believe.
But who's whose drive and which drive? Is it my drive or is it like the Essex PTA drive that you guys use?
Not the Essex one. The one that's like linked to the schooling emails, I think.
Correct, but if you have it linked to your Google Drive, you have to share it with me. You got to share it with my email.
Would it be easier to just email you, or?
No, you can just share the link. Like you just go to the video on your Google Drive and just share it to my Essex email. And that's how I've been viewing most of these emails.
I think I got you, Kev. Check again. Maybe you maybe refresh.
Okay. Still haven't gotten it yet.
And Mel, did you videotape anyone?
I did, and my sister.
You felt okay.
Yeah.
Very strange. Oh, I got it. Okay, yeah, sorry. I realize now. You were sending it to my personal email. Okay.
Oh, okay. I got personal. Sorry.
Yeah. Come on, guys. Keep it business. Keep it business. All right. Of course, now I gotta download your video, Joe. Gotta get viruses
that's
on
the thing.
here.
Right. I'm a pain in the ass. I know.
Yeah, it's just a lot of them to look at in that video. That's why it's so big.
All right.
It's a whole lot of Joe.
Moment.
Okay, got it. Play it. Okay. Whoops.
Yeah.
Yeah.
No, Devin. Yeah, I was making fun of Devin.
Yeah, what's up?
All right, who are we gonna put up now?
Sorry, I got Joe's video. I'm putting it up right now.
Joe, is this your wife?
No, I mean,
you should have done the pregnant gate though. That would have been good.
She said she'll do it. Come on.
Come on, Kel. Come on, Kel.
Hey man, where's the video? Here it is.
Oh boy. That was a lot of Joe to look at. I have those shorts on, Joe.
Look how wide. Toddler.
Why is his stand so wide? That's a pediatric gate, Joe.
I'm not doing good, man.
Joe, I could literally nutmeg you on every step you take.
That looks like my 16-month-old walking.
I actually have those videos too, Cindy, if you want me to play them. So.
Can we get side by side?
That's too advanced for me right now. I don't know. I don't have those kinds of IT powers.
He doesn't have the picture-in-picture power yet.
Yeah.
What do you guys see?
I see a very, very wide gate. It's almost choppy a little bit. There's not a lot of dorsiflexion on the left side.
This is a picture of some very, very tight individual.
Yeah.
This is the guy who doesn't stretch.
I mean, his it looks like his feet are out, but I don't know why it looks like maybe he's internally rotating. I see more in this angle. Like
I see. It's almost like his feet aren't straight, but I see internal rotation. Yeah, for sure.
Do you see internal rotation of the hip? Which hip?
Well, it's mostly when he's walking posteriorly. It looks like his left hip.
My left hip, yeah.
But is it internally rotated, or is it?
No, I think it's externally rotated. Slightly.
If it were internally rotated, wouldn't the foot come in?
Right, very kind of.
Yeah, right there on that
one step. On that one step right there.
This one?
Yeah, right there. You see how straight on his toes are? They're like directly straight ahead, whereas his other ones are.
Wait. But does that look internally rotated?
He'd have, if they were internally rotated, wouldn't he have more contact with the lateral 2 or 3 toes? Yeah. Maybe it's just a little abducted. He's getting good toe off on that left foot.
You guys think it was abducted? Maybe abducted.
Slightly.
But
Slightly, a little bit for sure.
And what does the femur look like it's doing? Does the femur look like it's
externally?
We gotta check.
Internally rotated?
That's I'm thinking internally rotated.
For the femur?
Yeah.
You don't see it down at the foot, right?
So you see a lot of adduction of the femur, which can indicate, again, some tightness or weakness. And I think he's very tight. I also think he's got a lot of weakness in the hips. That's why he has so much movement of the trunk.
I'm also, that kind of hurt my hip flexor on the right side.
He's got a lot of side to side movement, right?
Doesn't he have pronation of the left foot? No.
I think so, yeah.
Look at this carrying angle from an anterior to posterior view.
Right there.
Yeah.
Yeah.
He also has like a lot of trunk motion. It's not necessarily rotation, but it's just like going laterally side to side, deviation side to side.
Like a caveman.
Yeah. Why do you walk like?
Yeah, I was gonna say your arms are.
Wait a minute, guys. Let's just go with that right adduction of. Let's just look, just basically at this one. Right adduction of the femur, right? Increased carrying angle on the left side.
The left side.
Yeah.
Indicates a little bit more lateral flexion, right?
Yeah.
Lateral flexion, which may look at a little pelvic drop on the left, right? Which would indicate to you what?
Weak glute med.
Right, which would tie into everything we're seeing during this part of the gait, that stance part of the gait, which would be interesting to test him. But that's one thing. I mean, there's other things going on, but I just wanted to point out that one thing because you could see it pretty well in here.
So you got shorts on?
Yeah.
Can we see you squat too, like we did with Andrew?
Yeah.
Because I'm interested to see the glute med weakness if you have a shift in your squat.
Well, it's weird because I do a lot of hip abduction. I'm also, so I actually tried to start to skateboard again the past week or so, and I hurt my right hip flexor. So I don't know if that was you able to see that in that walk.
You could see that. You could definitely see that.
It was your right. See the stiffness.
You seemed like you weren't there wasn't an evenness with your rotation when you were walking.
No, so I definitely see something going on with your right hip. Let's see you perform hip abduction.
This okay?
When you say you do hip abduction exercises, how do you do them?
Oh, so a lot of it is with like the loop. I do a lot of like clamshells, kind of on the ground, side laying.
Can you do a sideline? Can you do a sideline hip abduction on the floor?
I can. Like I'm doing a fans only phase right now.
How much do you charge per month?
Free subscription. Isn't that bottom legging?
Oh, Joe.
And bring that top leg back so it's in line with your spine?
Yeah, that's a lot of TFL, buddy.
Oh, it looks like there's a lot of flexion.
A lot of flexion at that hip. He's not really getting he's not getting that glute med activation.
No way.
Yeah, Joe, when you're bringing that leg up, you see how it translates forward?
Hip flexion.
You're getting hip flexion.
Hip flexion and hip flexion, he's not using his glute med posterior at all.
Yeah, definitely not.
Joe, try that against the wall. Press your heel into a wall.
Yeah.
And then slide your heel up the wall.
So that's one of the big shifts we're seeing when he walks as well. Is that glute med that he's having issues activating, right?
Yeah. I think he's got a weak glute max too.
They're gonna look in the butt.
Yeah, a lot of. So when you're doing your abductor exercise, I think you're using a lot of your hip rotators instead.
Yeah. A lot of probably TFL too.
There's
Yeah, my TFL is like always, it's always turned on.
Let's see you do a squat.
You want to do lateral view, front?
Well, Kevin, you gonna take a picture of it?
Yeah, I can take a picture of it. Why don't we do front view first, and I can take a picture of it.
Back up a little more. Yeah, there you go.
Yeah,
we can't
it
really
would
see
be
your
nice.
ankles,
Yeah, it'd be nice if we could kind of see your foot. Are you using your laptop right now? Could you tilt the camera down a little? Yeah. All right. Yep, that's good.
Pretty small. Censor myself. All right.
Okay.
What do you guys think?
Looks like the left.
Looks like he's favoring left.
Left side. It's like a slight shift right to left.
Yeah, I have a picture of it, and you can see
right there.
Yeah, that was just even more exaggerated.
Similar what you saw in gait.
Joe, is that left foot also toed out a little bit more than the right side? Do you open that hip up a little bit more?
I'm just going to stay here. I'll drop down.
Yeah, it looks like the left side's definitely out more.
Definitely out more. He's getting a little bit more.
There's that shift to the left.
He
gets more flexion at the knee on the left than the right.
To the right, Joe.
Well, he also told you he injured his right hip. So
Yeah, he's definitely compensating for the right hip.
Yeah.
His hips will shift over to the left as he goes down. Right there.
There.
Yep.
Yeah.
Right.
Everyone see that? Yeah.
Yep.
So look at his ankles right now. What do you see?
So his left is pronated a little bit.
No, what else do you see?
Right.
His right's externally.
Yeah.
Right, so maybe he doesn't have the dorsiflexion on the right.
Joe, is surgery on the right side or the left side?
Joe, ankle surgery?
Ankle surgery on the right side?
Left or right side?
Ankle is on the right side.
Yeah,
right side.
And that's why.
So that's probably why he's lacking the dorsiflexion.
That or maybe the tattoo.
Too much ink. Too much ink in the area.
Scar tissue buildup under the tattoo, impeding dorsiflexion.
You guys saw that, as it pointed out, definitely everted ankle to substitute for the dorsiflexion loss on the right side. And that's why he did that.
The good thing is you guys are starting to notice things a little bit faster. You're noticing them, so I think this is pretty helpful.
Yeah, but I think you guys have also ruined us. We're going to stare at how people walk for the rest of our lives.
Oh, it's fun. It's really fun to do. Like, when I'm just watching people in the city, like, I just play games or I'm trying to figure out what's wrong with them just by watching them. And
your trips to the mall now will be totally different. You'll just sit on those benches with the old people and just watch people walk by. Like,
I'm going to be like, I could fix that. Fix that. Could fix you.
You need a card. You need a card. Everyone needs
referral.
I have a video of Steve.
Okay.
Yeah. So let's.
They see you stretching over there. Didn't that Superman pose?
My hip work here ain't tight. I have an awful couch.
Yeah, stretching the hip flexors. You could teach Joe how to do that. He probably needs it.
Oh man, Steve, your video is on some kind of file that I have to pay money for to be able to watch it.
OnlyFans.
Hey. It's like I have to download some kind of like codec and it costs some money to watch. I can't watch. You've been faked out by Steve, guys.
Can you look at my husband?
Sure.
He had an Achilles repair a couple years ago, and he complains a lot.
All right, John.
General or about?
Now, does that have to do with him being your husband or the Achilles?
Probably both, but no, he's complaining about actually shoulders. So I was telling him that it may be, I saw someone in the clinic, in my clinicals, that, her issues was with her plantars, but then the PT my CI was working on her shoulders. So I don't know if, part of it has to do with the gait, and he's complaining with his right shoulder, so.
Was the Achilles repair on the left side?
Good question. I think it's the right.
It looks like he's everting on the left.
So when you're taking video, it's best if you remain stationary.
Stationary, yeah, it's hard. It's hard to tell.
It's hard when you're trying to walk along.
Yeah. Because everything's a little blurry, but
Definitely everted on that part, though.
Yeah, for sure.
Yeah, I want to say it's left-sided just because of the difference in calf circumference. You can see the difference in size.
But it looks like, from this angle, it actually looks like his right side.
It looks like the right side actually the one that's lacking.
Yeah. So, all right, let's try.
No, I think it's the right Achilles.
You can tell from the side of the leg from there. It looks like his right side is.
Ooh.
Oh yeah.
That right foot is really straight. I might just be tripping.
Looks like he everts on both sides.
But you need some subtalar work on that, subtalar joint work on that, right?
Yeah.
It's like a whip on the left.
Yeah, he's getting a real, that leg really swings around.
Yeah.
I don't know if it's me, but does it look like his right shin almost like pushing out? Like almost, it seems like it's almost like borderline curved.
Yes. Mm-hmm. Absolutely. Yeah. It looks more varus.
Yeah.
Yes, he is.
Has he always had that?
Yes, since he was a kid.
Okay.
And when he's stepping with the left, he's stepping on the outside of his foot.
Yeah.
Yeah.
Yeah, so he stays pretty much in supination, right? He comes down to pronation but doesn't fully pronate.
Does it look like he adducts more on the right side? Like he almost steps in front of his left foot when he steps with the right.
Yeah, I agree.
That's sort of what I noticed too when he was walking.
When I said he had a lot of swing, that's kind of what I meant. Like it's got like almost a little circular or arc-like pattern for that foot when it swings around. And he crosses midline when he plants his heel.
Yeah, with the right side.
Got it pretty narrow.
Yeah.
Very, very narrow gait.
Right there.
But that may have the appearance of a narrow base because of.
Like I think it's
because of the varus. You think?
This next step here.
He's gonna wind up with OA of the right thing.
Andrew, right there, dude.
Yeah.
Yeah.
Goes into adduction on that right hip. Bang.
Right there.
Bang right there, and then that's
If his shorts were a little higher, we could see a lot more what's going on in there.
Mhm.
And look at the reciprocal arm swing too. Sometimes that tells you a lot about what's going on in the trunk too.
There really isn't a ton of arm swing.
Right.
So it looks like the carrying angle on the right is larger than the left.
You see more swing on the left, right?
Yeah, there's almost no swing.
No swing at